Good day, everyone. So this is going to be our video covering shock emergencies in the pre-hospital setting. It's also going to touch a little bit on IV therapy, IV fluids, and a little bit of IV theory. The presentation I've created, it has all the points from the slideshow presentation if that's what you're going to be using to follow along with. I can share this presentation if people want it. The problem I had with the slideshow is I found it kind of bounced a lot back and forth between different, you know, uh, theories, pathologies, and kinds of signs and symptoms instead of just having them all grouped together. So with this presentation, I've tried to kind of keep it all, certain themes and stuff together in one section, so it's not like we have to go back and forth and discuss it multiple times. I will go back and forth. I will look at the slideshow bit so I can kind of at least track where I'm going through if somebody is trying to follow with the slideshow that's available on Moodle, but for the most part, I'm going to be working off this document I have here in front of me. When I send the email for this video, I can provide these with that link as well. So other than that, we'll just jump right into it. It should probably be a little bit of a longer video. It's got a few themes and stuff that we have to spend some time on to, make sure we all have a good grasp on it. But, I'm looking probably at least another hour and a half video. So you'll know better than me because, you'll have the video in front of you, obviously, so you'll know how long it is. But again, if there's any questions or like that about this content, don't hesitate to reach out. So the first thing we're going to discuss is really what is shock, what is a shock state. You hear a lot, we always hear it all the time when we get dispatched through calls is, we have somebody who's in shock, and it's usually used a lot to describe kind of a mental state or an emotional state. Shock at its very core and its simplest terminology is basically a tissue that's being perfused below its normal level or its required levels. So we'll talk a little bit about different organs and different kind of time frames. We talked a little bit about it last chapter with hemorrhage control, but different parts of the body really are more susceptible to injury and dysfunction from shock, whereas like we talked a lot about, skeletal muscle would be more resistant to that type of injury just due to the nature of that tissue and its ability to kind of slow down its metabolic processes and kind of work off lactic acid for a longer period of time. When we look at causes of shock, we're basically looking at the collapse or the failure of our cardiovascular system. So we have, again, we'd look at our pump, you have the fluids, or we have the piping and the vasculature that kind of contain those fluids, right? So something within that circuitry is failing, and it's basically preventing the adequate supply of oxygenated blood and the removal of waste product from these tissues. Shock state, although we can look at side effects of shock, so whether it be, well, I shouldn't say just side effects, but kind of the precursors or the causes of shock or the side effects of shock, we never really can tell if a tissue's not being perfused or not, based from just an outward observation. So it's technically cannot be seen, but we can look at things like, is a patient experiencing anaphylaxis? Are they having a massive hemorrhage, which is, leading us down the route to think, oh yeah, they're going to be, dealing with shock because their volume is being depleted. We can look at symptoms and signs like blood pressure changes, heart rate changes, pallor to tissues, things like that, right? So although we can't really, pinpointly say, yes, they're not perfusing properly, we can look at other signs and symptoms to really give us a good indication that they're heading down that path of entering a shock state. Shock isn't a specific disease process or injury, although certain illnesses and injuries can provoke shock states. So kind of like what I just said, it's not like you're diagnosed with shock. It's you usually have a attributing injury that's kind of put you in this shock state. So again, when we're looking at diagnosing shock, when again it's going to be a very difficult thing in the pre-hospital setting, but it's going to rely on our ability as paramedics to assess and interpret basically a variety of different signs and symptoms to interpret a patient's level of tissue perfusion. So usually one of the easiest ones we look for is changes in mental state, or signs of kind of anxiety or restlessness. That's usually one of those first kind of physical or um, presenting manifestations we have of shock state, that a patient's body is starting to notice it's decompensating or not able to maintain its fluid volumes. And we'll talk about that when we get further down into this lecture. But again, since it's not a outwardly visible problem, or I should say symptom, like shock isn't visible as a perfusion problem, we have to rely on our ability to assess other body systems and vitals to really get a good interpretation if we're dealing with shock or not something else maybe. So being able to identify the severity of an injury or a disease, so this point right here, and then we can attempt to identify if this injury or disease is actually overwhelming the normal compensatory mechanisms of the body. So the normal compensatory mechanisms rely on our heart, blood vessels, blood volume. So if we're seeing a problem that's basically impeding one of those three portions of the cardiovascular system, we can start to try and narrow down what kind of shock state we might be dealing with, or what the actual underlying problem might be. If we are unable to identify these conditions or these problems and promptly address them, obviously the patient's situation or their shock state is going to progress further and further, and inevitably they'll deteriorate to the point where we can't reverse that shock state, and they've lost so much volume, or the volume's depleted to other areas of the body, that we can't really recover that patient from that state. And important to realize too that shock isn't just kind of a one one sign and symptom problem, or one precursor problem to it. It's got multiple etiologies, so you can have a number of things kind of accumulate together to create a shock state, and we'll talk about a couple of those in the chapter as we keep going here. So at this point in the slideshow begins to talk about different mechanisms of shock. It goes in through cardiogenic shock, hypovolemic shock, neurogenic shock. What I'm going to do is I'm going to finish talking about the actual kind of pathology behind shock states, what's the main problem with shock and why it affects the body the way it does. And what I'm going to do is kind of circle back to these mechanisms later on, because the actual slideshow kind of continues to talk about them later on in the presentation, and I think it'd just be better if we kind of keep it all in one area and then discuss it as a whole instead of going back and forth. So I'll continue this next part here. It'll probably carry on at about slide 82. So we're going to be talking about maintaining blood pressure and kind of our compensatory mechanisms and what the body actually does to try and combat different shock states. So when we look at shock, I'll switch myself so I'm not being stared at here. Probably want to look at this more than my visage. So the problem with shock is we're looking at basically states of persistent hypoperfusion. And remember, this is the tissue or organ that's not receiving adequate blood flow. It's not getting the amount of oxygen, and we're not removing that waste product at the rate that's kind of required for it to either maintain its normal function or maintain that aerobic metabolism, which most of our body relies on to avoid injury from byproducts, which we'll talk about later on. So when we look at persistent hyperperfusion, the first thing the body's going to try and do is it's going to try and increase that cardiac output, right? So it's going to increase its heart rate. It wants to kind of increase that preload, stretch that heart, and try to get that more blood volume to leave the heart. And what that ends up doing is it's going to increase the myocardial demand for oxygen. And, you know, as the body's having more increased difficulty providing oxygenated blood, the heart is actually requiring more oxygenated blood to kind of keep up with this demand. So it kind of tends to be a negative feedback. It, can kind of start to um, provoke the problem more. But I mean, obviously, it's the only mechanism we have to try and resolve this issue. So as the shock state progresses, if it's uncorrected, these compensatory mechanisms we'll talk about later on will begin to fail, and the body will, not be able to maintain its blood pressure. And that's when the body really has to start deciding on, which tissues can it start to kind of move blood away from to kind of keep it to the core. So, it wants to keep our kidney, our brain, and obviously our heart perfused with oxygenated blood so it can kind of keep functioning. So that's when it kind of has to start deciding what systems are most important, which ones can it kind of, forego for hopefully not a permanent, but a short amount of time. So as these volumes deplete, like I mentioned, preload and afterload, depletes. So if we remember Starling's law, right, where if we're not really stretching that heart out, if we're not getting that good preload, we're not going to have good contraction. We're not going to have an adequate ejection fraction, which means that inevitably the cardiac output will decrease. And again, that's going to further worsen our shock problem if we're not having that cardiac output that we need. As these pressures continue to decrease, we'll have tissue and organ perfusion decreases in perfusion to the tissues or organs, I guess we'll say. This, again, is going to cause, these tissues to kind of rely on a anaerobic metabolism, which will create more byproducts, waste products, acidosis, a few other things which we'll talk about in the next couple portions down here. And these waste products that anaerobic activity kind of creates will inevitably lead to cellular dysfunction, can lead to cellular death and breakdown. It increases vascular permeability. So if you think of your capillary beds, they'll start to open up and leak fluids out, which can end up leading to pulmonary or systemic edema if it's left uncorrected for too long. So this slide is going to be a little bit more information than what we need, especially when you look at the Krebs cycle and cellular metabolism. I just put it in there because I think it kind of paints a good picture on how complicated or how much our body relies on oxygen to really effectively create energy for cells and do the metabolism that all these cells rely on to effectively function. So I wrote the root of the shock emergencies is going to rely on this metabolic changes in each cell. So it's it stems down really to the impairment of a cell metabolism caused by inadequate bioavailability of oxygen. So oxygen is what we rely on for our mitochondria to actually process glucose. It's not going to actually process the glucose, but it's processing a component of glucose after it's been broken down partially, and requires oxygen to actually do that. So once that oxygen is not available, it kind of forces the cell to resort to a less efficient, more toxic anaerobic metabolism. So if you're looking at this while I talk, the top half here, this will be your anaerobic metabolism. So this is what actually just happens inside your cells all throughout your body. So anywhere in your cell, if you remember, like from grade 7 and grade 8, your cell, anywhere in that cytosol, which is basically the jelly inside of the cellular membrane, this is where your anaerobic metabolism kind of starts. the bottom half here, which would be your aerobic metabolism, this is what happens inside the mitochondria. So if we don't have oxygen available, the pyruvic acid, which is kind of what gets broken down into energy in the mitochondria, doesn't get pushed inside. So if you're kind of wondering where the oxygen kind of comes into play, it's right here. And that's what allows these molecules to go inside of the mitochondria to get processed into ATP. So the problem with anaerobic activity at the top is we have increased lactic acid production and metabolic acidosis. So you can see here, it by itself will create acids and lactic acid. And out of that whole process, we only end up with 2 ATP, or we'll just say 2 energy molecules from that breakdown. Whereas if you look at aerobic metabolism, yes, we're still going to end up making that lactic acid a little bit, or sorry, we're going to end up making this acid here. But out of the whole interaction, we end up with a total of, it ends up being a ratio can be anywhere from 32 to 34. There's a few different studies that, you know, they try to determine how much ATP mitochondria, the electron transport chain creates, but it doesn't really matter for you guys. The thing that's really important to notice is you're having, you know, over 15 times more energy being created through our aerobic metabolism. So with the increased acidosis created by anaerobic metabolism, hemoglobin is unable to really carry oxygen as well as it normally was. So what happens in the body is when hemoglobin gets into a acidotic state, oxygen doesn't really want to bind to it as well as it normally was. It tends to not really have any affinity to oxygen. So if we think we're already in that hypoxic state, or we're not having our oxygen demands met, if we're not having the capability to carry oxygen as well, it's going to kind of further provoke this problem, right? So again, I kind of mentioned this already, but with our anaerobic metabolism, we have decreased ATP, or adenosine triphosphate production. And this is kind of the energy currency of the body. Every cell in your body uses this ATP to function and do its normal cellular function. So when you look at, you know, cells like myocardial cells, neurons and stuff like that, that's heavily reliant on ATP to kind of, you know, continue its normal functions. With the anaerobic metabolism, we have to deal with electrolyte shifts. So we're going to be producing more of these hydrogen ions. Lactic acid is going to cause some shifts in sodium and other ions as well. So this can lead to cellular edema from, you know, fluids trying to shift in and out of the cell to compensate for these movements of electrolytes. As the cell kind of enters these acidotic states, lysosomes, which are kind of pockets of, trying to think of a good word to describe. They're basically enzymes that are in these little globules inside of most cells. And what they're normally used for is to help break down bacteria or other pathogens which might enter the cell. Once the cell kind of enters these acidotic, stressed out states during prolonged anaerobic activity, these lysosome pouches can actually spontaneously open within a cell, and kind of causes it to autophagocytize itself, and basically just destroys the cell, and the cell ends up dying from these enzymes kind of leaking within it. This last point is kind of a late end state one, but catecholamines and cortisol, that's usually released from your central nervous system from the stress state, but that'll spike blood sugar, which again, when you look at the cellular level, it'll kind of cause fluid shifts and you know, fluids to try to balance themselves across the cell membrane, which will cause, you know, further problems. So the big takeaway points, I think, when we look at anaerobic versus aerobic metabolism in these cells is the anaerobic. You're creating this lactic acid and you're only getting 2 ATP from it. Whereas your aerobic activity, you're still producing this one, normal, or should I say those 2 hydrogen ions, which is some acid, but this pyruvic acid is actually getting broken down inside the mitochondria, and we're getting that 32 to 34 ATP per transaction or per um, you know pyruvate molecule breakdown. So again, in the shock state, when we don't have this oxygen right here available to the cell, it relies on this kind of toxic, inefficient energy method, which builds up all these waste products and stuff really quickly in the body. So now that we kind of understand what's going on with shock and what's going on with this cellular metabolism, and what's uh, what's the underlying issues, we can kind of start to develop a sense on who's at high risk, what injury should we look for, and what bodily responses should we be trying to observe with these patients. So obviously patients who have a known trauma or bleeding injury, those are going to be people that we're already going to be kind of fearful of them going into a shock state. Elderly population, we've talked about this a number of times, they have reduced compensatory mechanisms. Their vasal tone isn't that great. They don't have as quick as a response and availability for cardiac output when you look at their rate. And they also might be on medications that kind of impede or prevent the proper response of these compensatory mechanisms. Again, patients suffering from a massive myocardial infarction, if there's dysfunction to the heart muscle, obviously we're not going to be able to increase the cardiac workload because it's already suffering a bit. Pregnant women, we've talked about their fluid volume. They have up to, I think it was 40% increase in blood volume. So when they start to lose that increased blood volume that they need to maintain perfusion to the umbilical cord and the placenta, their own, while they're trying to maintain their own metabolic functions as well, right? Because when you think of a pregnant woman, they're breathing for their own metabolism plus the baby's metabolism. So there's a lot of functions that the mother is providing for both her and the fetus, that if they go into these shock states, they're going to be at high risk of kind of succumbing to these problems. And as I mentioned before, if not just the mother, you're at high risk of losing that baby as well, with any kind of shifts in that blood pressure or perfusion to the to that umbilical cord. Patients with sources of infections, which can lead to septic shock. We'll talk about septic shock later on in this presentation. But any kind of thing that is going to make them more likely to be susceptible to an infection. So you think of burns like open injuries, right? So if you have burns where your protective layer of epithelial tissue has been sloughed off, then you're kind of exposed to every pathogen that might be on your tissue. It could be things even like large open wounds, penetrating traumas to the abdominal viscera, where you're having stomach contents or fecal matter kind of mixed in with your other bodily contents. Things like perforated bowels, where you have, again, fecal matter kind of in the abdominal cavity, which is going to cause infection and immune responses. But also things like diabetes. You have poor peripheral circulation. You're more prone to tissue breakdown, and then obviously cancer, if they're on immunosuppressants or immunotherapies, they're more likely, if they catch a small cold, they can kind of develop a widespread infection pretty quickly. So this next part here is a little bit of a longer one. It's going to be kind of talking about what compensatory mechanisms our bodies have to help maintain our blood pressure and combat these shock states and these symptoms that we experience during these injuries or disease processes. So at the core of it all, their goal is to maintain our blood pressure. and maintain that perfusion, which we talked about, in the first part of this presentation. It's kind of revolves around the central homeostatic mechanism, um, which regulates our cardiovascular dynamics. So when you think of cardiovascular dynamics, again, think of cardiac output, heart rate, preload, those kind of things, right? Ejection fractions, and these are all, in aims to help adjust and maintain adequate blood pressure. This mainly is driven off what's called baroreceptors. So again, if you're a person like me that likes to kind of get the root of the word to understand what's going on, baro, if you remember, that's pressure, and then receptor is obviously just a receptor. So it's a pressure receptor that is located somewhere in the body. And the two main ones, or the two big ones that the body uses, is in the aortic arch of the heart, which would be right there, and then in the carotid sinuses in your neck. And I'm pointing my neck, but where your carotid arteries run. And you can see my little drawings there. That's kind of where we're looking at for these baroreceptors. And the way these work is they basically sense the stretch of the artery that they're kind of housed in. So obviously the one in the aortic arch, it's trying to determine and make sure there's a sufficient amount of blood pressure that's leaving the heart to A, perfuse the coronary arteries, and then B, perfuse the rest of the body. So its main goal, or its main focus, is to make sure there's enough of a mean arterial pressure to perfuse the heart. And when you look at the carotid sinuses up in the neck, it's more worried about perfusion of brain and kind of more of a systemic circulation. So there's a few old like medical tricks they used to do. So people with high blood pressure, heart rates, they would actually do what was called a carotid sinus massage. Don't do it on yourself, because if you do it too much, it can actually cause you to pass out. But what it'll actually do is slow your heart rate down and try and, it's assuming that your blood pressure is really high if you're massaging your carotid sinuses. So it was kind of like an old medical, well, it might still be used, but anyways, that's something that's done. We'll just leave it at that. So stimulation of these baroreceptors actually will begin to occur when our blood pressure is anywhere between 60 and 80 millimeters of mercury in adults. It'll be a little bit lower in children because they normally have a lower blood pressure. But once the blood pressure is getting down to those levels, and we're starting to worry about the coronary arteries not really receiving sufficient blood flow. As drops in arterial pressure continue to decrease, stretching of arterial walls will be less noticeable. These baroreceptors will receive less stimulation. The decreasing of the baroreceptor firing will stimulate a vasoconstrictor center in the medulla. So if you remember from our little chats with the respiratory center in the brain, that's kind of overseeing heart rate, vasoconstriction, kind of some of those core bodily functions that are in the brainstem. During this response, our sympathetic nervous system is also stimulated, and it's gonna start shooting out epinephrine, norepinephrine, and that's gonna also increase vasal tone and heart rate as well through its own mechanisms. So when you look at the function of these two hormones, they're released by the adrenal glands. Those are located on top of your kidneys, in case you guys forget from A and P. But these are basically going to be an acute response to hypoperfusion. So again, the body is sensing that there's a decrease in perfusion to tissues, and those baroreceptors aren't being stimulated appropriately. This is the one of the first things the body's going to try and do to resolve that. One thing that we should note is epinephrine should be something that you've at least read up, hoping at this point, once or twice. It's something we carry in our first response or symptom relief kit, and it can be used in instances of anaphylaxis, acute bronchoconstriction, and if you're working with an ACP, it's also used in cardiac arrest. So these are really potent medications that have, a few widespread functions in the body and can help us in a few different instances when we're dealing with emergencies. So epinephrine, it's going to improve our cardiac output by increasing our pulse rate and our pulse strength. So it's going to increase stretch on the heart, and the Starling law, it's going to increase stretch. So when we increase our contractile strength, which is going to increase the ejection fraction, which is going to inevitably increase the cardiac output. It works through an alpha 1 mechanism, and we talked about this a little bit with the respiratory system, but you're looking at vasoconstriction. So that's going to be vasoconstriction of the peripheral, which is going to help shunt that blood back to the core. It's going to increase vascular resistance. So if you think of all those kind of other blood vessels through the body, all those capillary beds, if they're closing down, that's going to increase more pressure in the core part of the body, which is going to increase that afterload on the heart. And that'll inevitably help us also increase a little bit of a preload too. Norepinephrine, that's the second hormone that's also released, and it's more focused on the alpha 2 response, and it's kind of used to help back regulate a little bit of the alpha 1 effects. It also is used to kind of modulate alpha 1 and alpha 2 receptors. So think of epinephrine as kind of like your gas pedal, and norepinephrine is going to be the one that's going to be the brake, or the kind of balance it out, and ensure that you're not sending the that vasoconstriction into override, or you're not vasoconstricting, say, like all of your arteries around your kidneys. You're not constricting your coronary arteries and stuff like that, right? So we want to make sure that there's kind of a check and balance with these two hormones. When we look at trauma, we have what's called the golden hour, and basically most vital organs, aside from the heart and the brain, which have a very short window, but most of our other organs, if you have them inadequately perfused for greater than 60 minutes or so, you're going to have permanent damage. You're going to have complications. Basically, you have that 1 hour, that golden hour, is kind of our time frame to getting these people to the hospital or resolving the shock state. Because if they sit in that state for longer than that, they're likely going to have permanent damage to certain tissues. So on slide 83 of the PowerPoint presentation, we start talking about what's called the renin-angiotensin-aldosterone system. You can also just call it the RAS response, whatever kind of helps it stick in your head. It's going to kind of revolve around a few different hormones. I'm pretty sure you guys haven't really gone through the endocrine system yet. If you have, this will be hopefully a little bit of a review, but I'm going to kind of go into it a little bit here, just because it's pretty important, especially when we start talking about pharmacology and patient care theory too. And there's a lot of medications that kind of work off this system, so having a pretty good understanding of what's going on here will be beneficial, I think, for all of us. So the first thing to kind of understand is the first part of this is called angiotensinogen, and this is a molecule it's always secreted by the liver. It's kind of always available in our body. It's just always floating around. It's not something that's secreted when we're in a shock state or when there's a problem. It's always there as a precursor molecule to kind of response in this if there should ever be an emergency state. We'll talk about that at the end. So the first part of this is, when we look at the renal system, is we have what's called our glomerula, right? Which is a pocket of blood vessel which kind of goes in to the juxtaglomerular apparatus of a nephron. And if you remember, your nephron has all this stuff and eventually leads out to your ureter, and that's where pee comes from. The way the body works, and it has this pretty cool mechanism, is it'll actually sense the amount of perfusion or the amount of pressure in this little portion of the nephron right here. And what happens is if the renal system is kind of sensing that there's a decreased amount of perfusion at this site, it's going to start releasing an enzyme or a molecule called renin. And what renin's going to do is it's going to find these angiotensinogen molecules in the body, or in the circulation, I say, the blood supply, and it's going to meet up with them. And what it's going to do is, you can see here, it's going to cleave off a little chunk of that molecule. And that's going to leave us with this new part here. And you can see in the light purple, and that's called angiotensin 1. So that's kind of the first step to this molecule that's going to end up kind of helping us with our shock states. There's another molecule that's released. It comes from the epithelial tissues of the kidney as well, and it also comes mostly from the epithelial tissue of the lungs. And it's called either ACE, or the actual name for it is angiotensin converting enzyme. And if you can imagine what it's going to do to angiotensin, it's going to convert it into a different chemical, or a different molecule, I should say. So when we get into pharmacology, we're going to have medications called ACE inhibitors. So we'll talk about that later when we get into that. But again, that's why I kind of think it's important to understand what's going on with this RAS system here, this response. So you can see here, this ACE, or angiotensin converting enzyme, is going to make its way into the blood system, and it's going to meet up with the angiotensin 1 molecule that was previously cleaved. And when it meets up, it's going to cut another part of that molecule off right here. So you can see it's now this shortened protein, and what's going to be known as angiotensin 2. So angiotensin 2 is kind of like the final form of this enzyme, or this protein, which is really what it is at the end of the day. And what this does is it goes into our systemic circulation, and it's going to kind of act on a few different parts of the body, and we'll talk about them right here. So kind of the first one, the big one it does, is it's going to go all the way, make its way into the adrenal cortex, and it's going to cause the body to secrete what's called aldosterone, and that's another hormone. And this is going to help stimulate the retention of water, salt, and chlorine in the nephron. So it's going to basically prevent you from urinating more of that fluid out. So it's going to say, we have low blood pressure, or there's something going on with their fluid volume, so we need to keep this water in our system, so stop peeing it out. Angiotensin 2 will also directly work on the distal portion of the nephron to encourage the reabsorption of sodium, chlorine, and water as well. Angiotensin 2 has a direct sympathetic response as well, so it'll increase heart rate. It'll kind of increase that epinephrine secretion. And it's going to be attempting to increase that cardiac output through those mechanisms. Angiotensin 2 will also increase arterial vasoconstriction, so it's going to kind of work on its own to provide a little bit of that sympathetic style of response, but it's through its own mechanisms. And then finally, it's going to make itself all the way up to the pituitary gland. And what it's going to do is cause the pituitary gland to secrete what's called antidiuretic hormone, or ADH they call it sometimes. And this is going to make its way back to, this hormone makes itself all the way back to the collecting duct, which kind of like is that last portion of the nephron where it's kind of like the last chance that we have to reabsorb any kind of water or salt or like that. and it'll, make that last ditch effort. It's going to pull more water, more salt, or I keep saying salt, more sodium and more chlorine ions from the that collecting duct in an attempt to keep our blood volume increased. So this is kind of one of those feedback loop mechanisms. So as the blood pressure stays low, it's going to keep pumping out this renin from, the kidney. But once the kidney is able to sense that the blood pressure is returned to normal, is maintained, it's going to cut off that supply of renin, and then the system kind of auto regulates, shuts itself off. So at the end, the RAS response, it's in our body's initial response, to a blood loss or a volume loss state, and it's going to be one of our initial compensatory mechanisms. And its main goal is to increase our preload stroke volume. It's going to increase our pulse rate, and all that is, again, just to help improve our cardiac output, hopefully. But things to keep in mind too, right? If we have, say, example, somebody who's been chronically dehydrated, this might not work, right? If there's no fluid to reabsorb, there's no urine being produced, then we're not likely going to have the opportunity to reabsorb any fluids from that like that avenue, I guess you could say. Things like if we are already if we have medications that are preventing vasoconstriction, this avenue might not work. So it relies on the patient's what should I say, the patient's ability to kind of meet these needs, or have these kind of reserves stored, I guess you could say, to respond to this appropriately. So again, you can look online. There's tons of diagrams of this. This is kind of the way that makes sense to me. I always think of, again, it's going to be this long protein that's floating through the body, and these little enzymes that kind of get added onto it will actually, they're not added on, but they actually cleave off. So they cut off chunks of these proteins until you get what's effectively the active part of it, which would be this little chunk of it right here. So when it's in this full long form up here, this big long string, it's unable to, provide the function. It's not an active protein. So it has to be cut up for it to actually work properly. So this is the part we're going to start talking about different types of shock, different classifications, and kind of the underlying ideologies behind them. I believe they first start talking about different shock states on slide 76 in the slideshow. We're kind of starting off this slide here. This information here is actually available on slide 94. But again, I felt like, kind of bouncing back and forth through it all was going to be more complicated instead of just presenting it all at one instance here. So we're going to start by kind of using what's called a Wheel-Shubin classification. I've never really heard it called that, but basically what we're trying to do is we're looking at shock from a mechanical perspective. So what is the underlying cause of shock? And there's a few different mechanisms which we'll talk about as we keep going through this. But so the way it's broken down is they have what's called central shock. So that's going to be something in the core of the body, or they have what's called peripheral shock, which is going to be something that's affecting kind of the whole body, or more affecting the peripheral limbs. So the ones that we have looking at central shock would be cardiogenic shock, which has to do with the heart, and obstructive, which would be kind of it's in the name, like an obstruction of a major artery or something in the heart that's preventing blood flow. And then finally, in the extremities, you have what's going to be looking at like hypovolemic shock, so that'd be a fluid loss or volume loss, or distributive shock, which would be I've kind of drawn this doodle a few times. If you think of your blood being in the container, and then all of a sudden the container gets really large and the blood volume is only able to fill up to that much, that's distributive shock, where the increased I'm trying to think, the increased size of the container um, isn't, or is overwhelming the actual volume of blood that you have. So the blood is not actually adequately able to fill that volume of vasculature. It's important to remember though that all of these shock states, they're going to be characterized by reduced cardiac output. So that's kind of our main thing we're looking at is, you know, no matter what the shock, description is, we're looking at these problems leading to reduced cardiac output, circulatory insufficiency, and you're gonna have signs like tachycardia, hyperventilation. These symptoms that we kind of talked a little bit about above with the different response compensatory mechanisms of the body. Some of them might include pallor. So if you look at like an obstructive shock state or something with the core, you're probably not going to get pallor as much as you would with a distributive shock or something like that. You might get ultramentation depending on the blood pressure at the head, at the brain, and blood pressure. If you have that, it's usually going to be a late sign, especially if you find it in children. So this next chunk we're going through is going to be the shock etiologies. It's got a few. There's a few of them, but I just want everyone to kind of think back to the stuff we talked about in the first part of this chapter, or this lecture, I should say, is that we're looking at reasons that are causing reduced cardiac output. So I know we've talked a lot about preload and congestive heart failure and kind of backlogging of blood, but this one is, remember to try and think of it as things that are affecting cardiac output or outflow of blood from the heart. So I feel like I've hopefully covered them enough that it makes sense, but if there's any confusion, again, just email me, we can talk about it. So with the first one's going to be cardiogenic shock. So I always think of cardiogenic as, get my little highlighter here, cardio, heart, genic, root. So derived from heart is kind of the way I look at it. It's shock derived from the heart. So again, it's going to be failure of the heart's ability to pump due to muscle dysfunction. So it's an actual problem with the heart itself, not things surrounding it. So it's important to note this is going to occur secondary. So, myocardial infarction isn't directly causing the shock state. It's the heart's muscle dysfunction that's going to end up causing it, right? So it's I guess kind of a moot or like nitpicky point, but don't think of it as there's a blockage through the coronary artery that's causing the blood not to flow properly through the heart, through the body. It's not how it's working. It's the cardiac muscles become irritable. It's not functioning. It's not contracting properly. So we're losing our contractile force through the body. That's probably the best way to look at it. So when we look at myocardial infarctions, if you think about which part of the heart's going to be pumping to the systemic circulation, you're looking at left ventricle. I knew I drew it on the right side here, but if you have your left ventricle is going to be damaged or not contracting properly due to an infarction. So say if you had like a blockage somewhere in here, then you're losing the force that's kind of able to overcome the afterload and actually provide that systemic circulation. So if you find people that have, when we'll talk about it in patient care theory too, when we get into 12 lead and STEMI reading, but if you find somebody who has left ventricular infarct or problems with the left ventricle, they are very susceptible to going into cardiogenic shock states. And once they kind of go down that path, it's really tough to help. It's really difficult to have them recover from it if there's a large amount of tissue damage to that left ventricle. So I think they said something like if there's 40% damage, they usually can't kind of recover from it. And sometimes these patients end up having to get what's called an LVAD. And that's essentially just a kind of it's a little pump that kind of sits. I don't know if they actually attach it right to your heart, but it's like a mechanical heart or a pump. And what it'll actually do is it'll, circulate blood through the body for you. So these patients, they won't have, they won't have a pulse. They won't have a blood pressure because there's no actual mechanical squeezing of a heart. It's just a constant kind of circulating. If you think of it like a pump on a hot tub or something like that, that's essentially what it's going to be. Other reasons for cardiogenic shock will be cardiac arrhythmias. We spent quite a bit of time talking about this in Unit 5. So things like SVT, ventricular tachycardia, ventricular fibrillation, these rhythms, where the heart's not, you know, contracting in a coordinated way we'll say for ventricular fibrillation. Ventricular tachycardia, where it's it's pumping so quickly that it's not actually able to fill properly. And that's actually the same with SVT. The contractile rate of the ventricles is so quick that it's not actually able to preload itself enough to get a good cardiac output. So your ejection fractions are actually decreased significantly. Things like pulmonary embolisms, for example, those, say right here, kind of drew this brown section. If you have a large vessel in the lungs that's occluded with a emboli of some sort, it can actually cause a backlog of blood flow, and it'll actually prevent adequate upstream flow of blood. So let's draw this in a different color. It's going to prevent the normal amount of blood flow returning to the heart to kind of be met, which can actually reduce the ejection fraction of the left ventricle if it's a substantial enough emboli or an occlusion in the pulmonary artery somewhere. And finally, severe acidosis. This can cause dysfunction of the heart. The myocardial cells will become agitated, irritable. We talked about that when precursors to arrhythmias. But with much of the same of any kind of function in the body, if we try to have those same functions run in an acidotic state, it's usually met with a lot of dysfunction and problems. So again, looking at the cardiogenic shock states, the big thing to kind of remember is that as these progress, we're going to have reduction of our preload on the heart, which is going to inevitably reduce the ejection fraction and our cardiac output for the whole system. So it's kind of, again, one of these systems that kind of will self provoke itself. It gets worse and worse as time goes. As you get reduced cardiac output, then there's reduced preload, and it kind of just perpetuates that way. Another important thing to kind of think of is cardiogenic shock. Can be a result of a major acute event. So think of a large myocardial infarction. That's the big one I can think of, but it can have one big event. But another thing to think about too is if you have somebody who's had a cumulative atherosclerosis or maybe prolonged angina or repeat episodes of angina where they've kind of damaged the cardiac tissue on a kind of a more chronic long-term level, they can still get or develop cardiogenic shock or cardiac dysfunction to the point where they'll get cardiogenic shock. It just might not be one massive or sudden problem that kind of leads to it. So we're going to continue with obstructive shock. And cardiogenic shock can kind of fall into this category of obstructive shock, depending on the actual mechanisms. They kind of can overlap a little bit. But basically what we're looking at with obstructive shock is a blockage or a constriction of the heart or the blood vessels that feed the heart. And this is going to inhibit the heart's either ability to pump blood or to actively fill with blood and appropriately, um, pump it out. So one of the big ones we've discussed before briefly is pericardial tamponade. And this is, again, if you remember from A&P, you have that pericardial sac which surrounds the heart. And if this becomes filled with fluid, whether it be blood or liquids from an infection or something like that, what's going to end up happening is it's going to squeeze the heart and it's going to apply a larger pressure to the outside of it, and it's actually results in it being unable to or incapable of relaxing completely and go into that diastole phase where the passive filling of blood would actually be happening. So this would effectively reduces the pre-filling or the preload of the heart, which at the end of the day, it's going to reduce the ejection fraction and your cardiac output for the heart itself. Things you can look for with pericardial tamponade is those distant heart sounds is one, or muffled heart sounds. Narrowing pulse pressure is the two big ones that you'll begin to see. The other big one is going to be a large embolus of the pulmonary arteries or veins, and or a tension pneumothorax is the other one. Did I not draw? I usually draw these. I don't know why I didn't draw this one. So if you remember from the respiratory system, we talked about the mediastinum, which is kind of like that middle pouch that holds the heart, the vena cava, kind of like the central vasculature that kind of runs through the core of the body. And then on either side, you have your thoracic cavity, which houses your lungs. And if you think with, for example, a tension pneumothorax, is if you had that, I'll just do a quick doodle. I wasn't going to be doing these on the spot because they always never turn out as good as they should. But if your mediastinum's in the middle with your heart, if you have, say, for example, this area here is filling up with air from a hole or something like that. So we'll say we have air leaking in. Inevitably, what's going to happen is this whole cavity wants to shift over and fill up with air. And that's going to squeeze the heart, and it's going to be, again, obstructive shock, or it's going to be compressing it and preventing it from, filling appropriately. In some cases, too, you can actually have it where the vena cava gets blocked or compressed, and that's where you end up with signs like JVD. Blood pressure is obviously going to drop down. The heart might try to compensate with increased pulse rates. But that's the underlying problem with pulmonary. Not pulmonary. I meant to say pneumothorax. But it's the same idea when you look at an obstruction of the pulmonary arteries as well, or a large vessel. You're basically going to have a blockage of that blood flow on a fluid level, right? So we're thinking of not so much of the other symptoms of, okay, we're not going to have oxygen exchange, we're not going to have, we're going to have atelectasis, we're going to have vascular shunting and all that stuff. We're not, it does happen, but we're not worried about that. We're thinking of just simply the blood isn't going to be able to circulate properly through the lungs now, and we're going to end up with a decreased amount of blood returning to the heart, which is going to cause a shock state. So that's kind of our obstructive and cardiogenic shock states. You know what? I'll just stop the recording and start a new recording in case I mess it up. Next one on our list is hypovolemic shock. So this is a loss of fluid, whether it be blood, plasma, or electrolyte. Obvious on the side here we have through a trauma injury, blood loss. But you can think of plasma loss through burns, electrolyte loss. Think of increased nausea, vomiting, diarrhea, stuff like that, where you're actually losing fluids from the body. And again, when you look at derivative of words, hypo, low, volemic, volume, so low volume. This tends to be one of the most common ones that we find in the pre-hospital setting. So it should be our primary suspicion. If we find they are, showing signs and symptoms of shock, but we can't really figure out why or what's causing it. If so, again, if we can't really determine what the etiology is, we should try to, kind of fall back on hypovolemia, possibly likely being the cause. So we have two kind of categories or classifications, I guess you could say, of hypovolemic shock. We have what's called exogenous, which would be outside of the body, so exo, outside, genus, body, or endogenous, or inside the body. And this is basically going to depend on where the fluid loss is actually occurring. So you're still dealing with a fluid loss. It's just they want to break it up and say, is this inside or outside of the body? Not going to really change your treatment. It's not going to really change your report or your paperwork. It's just so you kind of have a better understanding of where these fluids are actually shifting. So exogenous is most commonly found when we deal with external hemorrhages. So you look at like penetrating or blunt traumas that deal with open bleeds, long bone pelvic fractures with open injuries, and obviously major vascular injuries, multi-system injuries. So again, this is blood that's going to be leaving vasculature and the body. When we look at exsanguination due to these injuries, the highest ones that are of highest risk are the heart. Obviously, should be pretty self-explanatory. Liver, again, large blood supply that goes through there. It's used to filter all of our blood, so it's a high pressure system. So if it's lacerated or damaged, it'll leak large volumes of blood. And the spleen is kind of like our reserve for extra erythrocytes. It's got a large blood supply that can feed through it. So damage or rupture that can result in exsanguination quite quickly. And then obviously looking at thoracic vascular system, abdominal vascular system, you have your vena cava, your aortic arch, descending aorta, abdominal aorta. There's large vessels that run through these parts of the body. So any kind of damage to them, you're going to have, high likelihood of kind of rolling down into a shock state of hypovolemia. And then finally, I kind of mentioned this with the hemorrhagic injuries, the venous system. So remember that, veins have poor bleeding response or injury response. They're not really able to constrict down like an artery would or the capillary beds can. They kind of remain under low pressure, so they will tend to just ooze blood passively. And they also kind of rely on skeletal muscle and breathing to kind of facilitate blood flow through those veins, right? So they don't really have the ability to, clamp themselves down, and they're kind of what's called the capacitive blood supply of the body. So it tends to just hold blood in that part of the vasculature, right? So if it's damaged, it'll has nowhere to really put it. It'll just kind of spew it all out. So endogenous hypovolemia occurs when the fluid loss is contained within the body. So you're looking at things like dehydration, where it's, you're not actively losing blood, or you're not actively losing a fluid outside of the body. Burns, we talked about fluid shifts from cells that are damaged. Crush injuries, we talked about potassium shifts, rhabdomyolysis, stuff like that, right? And then anaphylaxis, which kind of relies on the immune response to the body, which we'll talk about a little further on down here when we get into anaphylactic shock. But anaphylaxis, again, you're going to be having releases of things like histamine and other inflammatory chemicals in the body, which is going to encourage the vasculature to become more leaky and leak its actual vascular volume out into interstitial tissues. Some other abnormal fluid shift and electrolyte losses that we can kind of have lead towards hypovolemic shock are problems with the gastrointestinal, gastrourinary systems. So if you look at uncontrolled vomiting, uncontrolled diarrhea, Patients who are on diuretic medications that maybe they've either taken too much or it's not maybe the dose isn't proper for that patient, and situations of polyuria, which is usually a side effect or a symptom of hyperglycemia. So that's the body's basically trying to get rid of sugar, but all it can do is urinate out the fluids. So that can lead to actual fluid depletions as well. Things like fevers, high environmental temperatures, increased sweating. You're actually losing that volume through your normal kind of homeostatic responses. You look at internal fluid shifts, so electrolyte imbalances. I always think of the story of if you drink like distilled water, for example, you're not going to have any ions in that water, so it actually kind of pulls ions from your systemic vasculature and can actually pull fluid with it. You always hear of people like that are in like bodybuilding or stuff like that, and they'll drink distilled water for a certain amount of time to kind of help them lose water weight or make them seem more dry, they call it, if they're going to do a show or something like that. So things like that can actually kind of provoke fluid loss or volume depletion. Other things like pancreatitis, peritonitis. So again, these are inflammations of different tissues or organs in the body. So if it's pulling fluid to kind of deal with these inflammations, then you're going to have reduced fluid volume for vasculature. Plasma losses, again, that can be done through burns externally. People that deal with severe edema to the extremities, you can actually have plasma leak through their tissues. There's a few different reasons for that. Ascites, so this is fluid shift into the abdominal cavity. You'll find these patients usually if they have some kind of an acute renal or hepatic failure. There's actually a kind of a back pressure of blood, I guess you could say, or a back pressure on these organs where, since the fluid has nowhere else to go, kind of just leaks into the abdominal cavity. People that frequently have to deal with ascites, they kind of like the really big distended abdomen is really tight, and they actually have to go to the hospital to have peritoneal synthesis done. Like they'll actually drain the fluid from the abdominal cavity. And again, renal failure, if you're thinking of anything with the kidneys, they kind of manage our blood volumes, our blood volumes and our renal output. So as I mentioned with the renin and angiotensin system, if there's dysfunction with that, you might have problems with actually managing your fluid volumes. So this next group's going to be kind of they're going to be under the category of distributive shock. So this is, if you think of the whole big box, small box kind of example I always use. If your blood's normally housed in a, say 1 centimeter by 1 centimeter by 1 centimeter volume, and all of a sudden you expand it to 5 by 5 by 5 centimeters, the amount of fluid that's in that box isn't going to be enough to fill the larger box. So it's the blood is being distributed inadequately to maintain blood pressure. It's probably the easiest way to think of that. So it's usually a result from the widespread dilation of our resistance vessels. So if you think of vessels that help increase afterload, and then our capacitance vessels, which are the ones that kind of hold our blood volume. So if you think of veins, capillary beds in our extremities, if they all of a sudden all dilate, it's basically going to increase that volume to a point where we don't have enough blood circulating to fill them all up. Again, so it's going to cause circulating blood to pool in these expanded vascular beds. Most common types of distributive shock include septic shock, which we're going to talk about, neurogenic shock, and anaphylactic shock. Again, we're going to talk about all three of these. Septic shock, this is the result of usually an infection. It's usually a profound kind of widespread infection. But the result of this is going to end up with hypotension in the patient, and you need to have the presence of a sepsis syndrome to actually have it diagnosed as a septic shock. And you may ask, what is a sepsis syndrome? Sepsis is simply a complex but unregulated immune response. So if you think of um, things as simple as like a UTI or pneumonia is not always simple, but sometimes people have their body respond to it so severely that they have uncontrolled fevers. They have a huge pyrogenic response, which is going to also cause the release of histamines and other immune response mechanisms. So this unregulated response results inevitably in acidosis. It's going to build up lactic acid in the body, which is going to provoke further dysfunction down the line with other metabolic processes, which we talked about earlier. It's going to end up leading to tissue destruction from the lysosomal breakdown that we talked about in the I believe it's when we talked about the Krebs cycle and the metabolic um, functions of anaerobic and aerobic activity. And this will end up leading to hypoperfusion of organs and tissues, obviously, if it's a shock state, right? Inevitably, this is going to lead to fluid depletion, leaking into interstitial spaces. With these immune responses, you're usually going to have that increased permeability of our vascular system. So you'll end up with leaking even into our respiratory spaces as well. So pulmonary edema, right? Again, with the kind of dilation and increased permeability of these vascular beds, you're going to end up with a larger than normal vascular bed volume, which is going to deplete the cardiovascular system. And, having the volume that's already been leaked out into some interstitial spaces or into the lungs, you already have a reduced volume that's trying to fill these increased spaces, so to speak. So that's kind of the short and sweet of septic shock. You can be looking for things like fevers, source of infections. They might have an end tidal that's really low. And if you remember, when we look at patients that have increased acidosis from lactic acid, the thing with lactic acid is that you can't breathe it out. It doesn't cross into the lungs through the alveoli. So while your body's trying to balance out the acidosis, all you're effectively doing is breathing off your carbonic acid, which ends up being your carbon dioxide, which will end up decreasing your CO2 levels. So that's what we call is metabolic acidosis from septic shock. It's where the metabolism of the body is actually creating the acidosis and not the breathing. And one I'm sure we've all heard of, maybe even come into contact with firsthand at some point, is anaphylactic shock. So this is a severe immune response to a foreign substance pathogen, whether it be an insect bite, a food, medication. There's a wide range of things that people can develop anaphylaxis to. And the thing with anaphylaxis is when you're exposed to these allergens, usually your first response is, I don't want to say mild, but can be milder. But the subsequent exposures, the body actually kind of ramps up its response. So you'll actually deal with more and more severe anaphylactic responses if they're ever exposed to those allergens again, I should say. So the severe immune response will actually cause widespread vascular dilation, and you're going to have that immense histamine response, and the other inflammatory components of the immune system also will respond to this foreign substance, I guess you could say. So it kind of has some of the same factors as you would look at with the septic shock with the immune response. With anaphylaxis, however, these immune chemicals, histamines, will also lead to bronchoconstriction. So if you think of people with anaphylaxis, you always think of, they have that, they're wheezing or they can't breathe or their throat's getting tight, right? Histamine also causes fluid to leak from vasculature into interstitial spaces. We talked about that just this last slide. And it can also cause edema, which will lead to swelling into the face and upper airways, which is obviously a risk when we're looking at managing the airway and breathing of a patient, and oxygenation. One important thing to look for that's kind of unique to anaphylaxis is what's called angioedema. So angio is face or front of the head, and edema is edema, swelling, right? So we're looking for swelling of subcutaneous tissues of the face, mouth, and or neck. And these will include the eyes, lips, forehead, and then it can also get into uvula, tongue. Sometimes people say their cheeks. But you'll find symptoms such as dyspnea. They'll have a hoarse voice. They might say they have an itchy throat. They might have difficulty speaking, swallowing. Those are kind of the hallmark findings when you look at edema into the mouth, face, and that angioedema kind of symptom. Important things to remember when we're looking at anaphylaxis and when you look at your ALS directive for anaphylaxis is usually you want to try and find a source of the probable or possible allergen. You want to look for the possible allergic source. But if you're looking at something and they meet kind of like all of these symptoms and you're like, you're saying they're short of breath, they can't breathe, their mouth's closing up, they have swelling to their face, and you can't seem to figure out what the allergic or the allergen might be, you're probably going to be more safe to give them the epinephrine or the Benadryl, whatever criteria they meet, than if you were to just kind of wait to see if you can find out if they accidentally ate a peanut or not. The same thing will go to somebody who, they don't have any known allergies, but maybe they, tried eating at a new restaurant or something like that, or they tried to have lobster or mussels or something like that for the first time. Then, they don't have a known allergy, but you have a high suspicion that they probably tried something that's triggering the system, right? So important thing for the anaphylactic shock is definitely review the ALS documentation for this. I know for a fact in the final exam there's some questions on it, and there's going to be some questions relating to anaphylactic shock in the Unit 6 test as well. So, know things like concentration of epinephrine that we're going to be using, what's their dosing, and what kind of signs and symptoms are we looking for to treat with anaphylactic shock. And if you remember with epinephrine, it's a alpha and beta response, right? So you're going to be looking at bronchodilation, vasoconstriction, increased cardiac output from increased heart rate, those kind of things. And I'm trying to think if there's anything else with anaphylaxis. With anaphylactic shock, you want to maybe read the companion document as well, which goes in to describe different body systems. So we talked a little bit here. So if you're looking at bronchoconstriction, that would be your respiratory system. Angioedema and swelling. Angioedema, that'd be like your integumentary system, right? So your face, blood pressure loss, increased heart rate, that'd be vascular system. Severe cases of anaphylaxis or allergic response, you can get nausea, vomiting, diarrhea. So that'd be the gastrointestinal tract. So there's going to be some questions about, how many systems would you consider this to be if they had this, and this. So try to look at, I know for a fact in the companion document, there's a breakdown of, major and minor systems. So make sure you're comfortable with that before you get to the test day for this. So other sorts of distributive shock is neurogenic shock. So we talked a little bit about problems that arise from TBIs and spinal injuries. Again, you're looking at the body's inability to properly vasoconstrict. So, I drew it here again, like I always seem to, but the blood volume that's normally in your closed system, now the system all of a sudden gets a lot larger, dilated. You're not having the adequate blood flow available to kind of meet those demands. So with neurogenic shock, we're looking at the sympathetic nervous system, which normally controls dilation and constriction of our vasculature. And if you deal with an injury, you're obviously going to have some kind of dysfunction of that ability, right? The actual circuitry has been cut off to a certain part of the body. So those vessels kind of return to a dilated state where they have no tone at all. So in a healthy individual, the lumen of the vessel is constantly changing. So for you or I sitting here, if we stand up really quickly, some vasculature is going to tighten up and get smaller. So the blood pressure kind of increases to our core and our brain to kind of accommodate for that change of position. Same thing when you get up out of bed. But if you have patients who are on medications that kind of reduce that effect or slow it down, you might have them get up from bed and all of a sudden they feel faint, or they might actually collapse or pass out from that. So people that have no medications or disease processes that actually impede this, we're able to kind of accommodate or respond to changes in body position, changes in blood volume, blood pressure pretty readily and effectively. So the problem is when you deal with some injuries, disease processes, they'll actually disrupt these functions and they'll lead to a loss of control of this vasoconstriction. So we're looking at, again, SCIs, TBIs, depending on what the actual area for the brain injury would be. So these injuries will actually cause a loss of vascular tone below the affected site. I drew a little bottom up here. So if you think you had an injury here, everything below that injury site might, if it's a complete SCI, you might lose all sympathetic tone. But again, it depends on the injury and how severe and what's affected. But you're looking at that sympathetic response being lost, and all of a sudden, all the vessels that those neurons would kind of innervate would be completely dilated, causing distributive shock. So this is usually characterized by skin, which will remain pink, warm, and dry. So you're not going to kind of see that, usually that kind of shock state that you'd see where the skin kind of blanches. You can tell it, the blood's being shunted away to back to the core to kind of respond to that shock state. And this is only going to be found, though, the kind of characteristic part of this is it's going to only be found below the injury site. So if you have let me just switch the camera here. Say you have a thoracic injury, for example, like say mid-thoracic back injury, spinal injury, you might have all the vasculature below, say like the nipple line, be completely dilated, so they'll be pink and they'll be warm, dry, like normal. And then at the top, the rest of the body's trying to compensate for the shock state now. So you'll actually have blanching, pallor to the hands. It'll be diaphoretic. Skin will be cold because all that vasculature, all that blood is being shunted away to the other parts of the body trying to respond to this now increased volume of blood vasculature. So again, sweating, pallor, and cool skin above the injury site as the body attempts to compensate. The one unique thing is there's going to be no release of epinephrine and norepinephrine because the body can't activate the sympathetic response due to the actual disconnect or the injury to that site, right? So it's not able to actually have that sympathetic response to those areas due to the injury. Just can't. It's a complete disconnect from that part of the body now. And remember, this will be unique to neurogenic shock. This whole part here. Spinal shock. This one always kind of confused me a little bit in school. So I'm going to try and make it as easy as I can for you. It's essentially the exact same thing as neurogenic shock. I just think of spinal shock as something that can be resolved or it could be temporary. It's kind of like that spinal concussion, or if you have swelling to the spinal cord. These are these things that can, if you can resolve the underlying problem that's causing it, then the actual symptoms may resolve. So again, it's a localized neurogenic dysfunction after a spinal injury, and it's going to cause motor sensory loss. It's kind of the same as the SCI in that regard. And again, with any kind of spinal injury, you're going to have that paralysis. If it's involving a sphincter, so rectal sphincter, urinary sphincters, they'll usually defecate or urinate themselves if they had any matter in those areas. If they had a bladder full, it'd lose that tone to keep it inside the bladder. So that's something you can look for. They're not going to have reflexes, pain, temperature, touch perception. They're not going to have proprioception. They're not going to have pressure sensation below the level of insult. Something we should be pretty comfortable with the idea of when we're dealing with spinal injuries, correct? Um, some things that we might not think of is the inability for them to actually thermoregulate. So they're not going to have the ability to vasoconstrict and keep warm blood towards the core. Blood's going to flow through all the capillary beds, so that circulating blood's going to eventually cool off, and when it returns to the body, it's going to reduce our body temperature. Things like shivering, those mechanisms aren't going to be responding as well. Things like if there's injury site above, like say the abdomen, they're not going to have somatic visceral sensations, so they're not going to feel gut pain, stuff like that, which is going to lead to things like bowel distension and loss of peristaltic function, so they're not going to actually be able to digest food. Bowel tone kind of just, it all relaxes, so their bowels become distended. Their gut, depending on, again, how high up, you have large small intestine distension. So those are things you're looking for, that those kind of come hand in hand with any kind of spinal injury. The big thing to remember, and you're like, well, what's the difference between that and neurogenic then? Because neurogenic is, it says here, from a disease, and you're dealing with the inability for the body to actually compensate its blood supply. It's more of a, is this going to be a long-term or a short-term thing that's going to resolve? That's the easy way for me to kind of break it down for one versus the other. So those are all the actual shock states, or the shock etiologies. What we're going to be talking about next is kind of like the events as shock progresses in the body, and as perfusion decreases, what we're going to be looking for as paramedics in the pre-hospital environment. So the first thing that's going to happen is we're going to have cellular ischemia. Cells aren't getting oxygenated properly. They're going to become more irritable. They're going to be going to that anaerobic response. We're having reduced blood flow passing through capillary beds, as certain parts of the body kind of shunt away their blood, try to respond to these shock states, again, depending on which shock state we're talking about. And again, so we're going to have our cells are going to move to anaerobic metabolism. This is going to be something that's only maintained temporarily as we kind of increase those lactic acid and metabolic waste products that circulate. We'll end up having cells that are autophagocyzing themselves with those lysosomes that are breaking down inside of them. So that's a step forward there. So these lysosomes use to defend themselves from bacteria. They'll rupture inside the cells, causing autophagocytosis. Inevitably this will lead to tissue and organ failure, tissue death. As more cells die, the waste products, carbon dioxide and acid, will accumulate. These waste products and kind of byproducts will actually act as vasodilators, and they will reduce venous return, which is the preload on our heart. As this preload kind of diminishes, we're going to lose mean arterial pressure, which is also known as our MAP. I'll talk about that in a second. But as soon as that drops below that 80 to 60 millimeters of mercury we talked about with those baroreceptors, the aorta will not be able to adequately fill the arteries, or coronary arteries, just to say. So once we get below that pressure, we're starting to worry about our oxygen supply for our myocardial cells. This again will start to kind of perpetuate and become a cycle of worsening problems here now. So as eventual reduced blood flow occurs, the vasomotor center of the brain will actually start to dysfunction, and we'll lose our responsive sympathetic nervous system response and activity. So as we lose that, then heart rate will decrease, vasoconstriction will start to decrease, and we're going to lose more pressure, more preload through that avenue as well. As these metabolic waste products accumulate in our slow flowing blood due to the decreased cardiac output and our increased vascular volume now, or I shouldn't say vascular volume, but our increased vascular spaces, I'll call it. Our platelets will start to agglutinate and aggregate, which will actually cause kind of like that sludging or clotting of the blood. And this will lead to what's called microthrombi, or small blood clots that are going to start forming in the blood. And then kind of near the end, ischemia and necrosis ultimately lead to organ dysfunction syndrome, organ failure, and then we talked about that golden hour. These organs will start to shut down, and they'll actually start to deteriorate and break down. One thing, we don't really have to calculate this in the field, but it's a good understanding, kind of, or good practice to understand what we're talking about. So mean arterial pressure, or MAP, has a calculation. This is what it looks like. You're going to take your systolic blood pressure and you're going to add 2 times your diastolic pressure, and you divide that whole thing by 3. So the example of the golden 120 over 80, so it'd be 120 plus 2 times 80, which is 160, and you divide that by 3, so you get 280 divided by 3, ends up being 93.3 millimeters of mercury. When you look at MAPs, a good MAP rating would be anywhere between 70 to 110. We're not really, again, it's not something we deal with right now. As we deal with large bleeds, or we have other directives that come out, it might be something that they want to try and have us use more often, because it gives us a more accurate determination of perfusion of tissues. So phases of shock. I've talked about this a little bit when we were talking about elderly population, pediatrics and stuff. But this is essentially, it's going to describe the parts of, or how our body is responding to these shock states, and if it's able to kind of maintain it or not. So there's 3 phases. There's technically 2 phases, and then one's kind of at the end of the line. But so the first one is going to be compensated shock, and this is the earliest stage. This is when your body recognizes there's a little bit of a depletion of blood volume. We're able to compensate that with vasoconstriction, the renin angiotensin system. There's a few things that the body's going to start doing to help resolve that problem. The important thing to remember with compensating shock is that we're able to maintain our blood pressure still. For the most part, you might see slight variations, but the body's able to maintain that blood pressure adequately. This usually means if it's some kind of hemorrhagic blood loss or hypovolemic blood loss, we're looking at a loss of about 15 to 30% of our total blood volume. That's kind of like the realm where our body's able to compensate for these shock states. One thing you might notice is a narrowing of the blood pressure slightly. You're not going to have a profound change because, like I said, it's still able to compensate, and it's able to, use our body's mechanisms to maintain perfusion. The next phase would be decompensating shock, or decompensating phase of shock. This is where our blood pressure notably begins to fall. It's usually in a result with a blood volume loss of over 30%. And this is where we start to see our normal compensatory measures start to fail. So, severe anaphylaxis, severe hypovolemia, stuff like that, right? Signs and symptoms of on our patient will become more evident. You're going to be seeing mottling of the skin. You might have pupils starting to dilate as cerebral perfusion kind of decreases. They'll have decrease of cardiac output, and you might have things like confusion, altered level of consciousness, stuff like that, as perfusion levels are actually starting to diminish slightly. Patients in this state, depending on how far they are through that state, they might be able to recover, they might not. It depends how quickly we're able to get them to the hospital and how quickly we can get them treated with blood products and um, things like vasopressors and stuff like that. And finally, irreversible stage or irreversible shock. So there's no amount of fluid or treatment that we can provide to that patient that's going to overcome the damage and the volume depletion. It's basically the point of no return. It's the end of the line. And I've kind of drawn it on a table. They have this on a slideshow. I found theirs was kind of ugly. So, um, diastolic pressure I've kind of left the same for everyone. It's, it'll obviously vary a little bit from adult to child, but for the most part, it follows the same path. But the big kind of takeaway point to remember when you look at these is, the systolic blood pressure of an adult, you can see up here at the top, they're able to compensate that for quite a while. And then they'll eventually get to the point where they start to decompensate and trend downward, right? I've always said this with pediatrics, they are able to compensate and they do that quite well. But once they've hit that point where they're not able to compensate anymore, they'll decompensate very quickly. So the scary thing with injuries to children or pediatrics is they might seem fine until they're not fine. It's kind of a quick turning point where if you don't resolve the underlying problem pretty quickly, they'll succumb to their injuries and go into this state of irreversible shock pretty quickly. Whereas with the adult, you're able to kind of see the trends a little bit sooner, and you're able to kind of might have a little bit more indications that they're kind of going down that decompensating road. So some signs and symptoms for hypovolemic shock. I mentioned this earlier, but the earliest signs with these shock states, you're going to have signs of restlessness, anxiety. Patient will seem afraid, they're restless, kind of thing, not able to sit still. They don't feel well. They'll have complaints of thirst and nausea. They want to get fluids back into their body. They're trying to replenish their lost volume. Important thing to remember: we definitely don't give anything orally for to any patient really, unless it's a medication. But we should not be giving oral medications or oral fluids to these patients at all, because they're going to be at high risk of requiring surgery in the long run. But in the short run, if they become unconscious, then you're going to be dealing with higher increased likelihood of emesis or airway compromise if you're giving them fluids beforehand. These patients, they'll end up having skin that becomes pale, cool, and clammy. Heart rate and respirate rates will increase as they attempt to oxygenate the remaining available red blood cells they have in their circulation. And if you get to the point where they have a falling blood pressure, it's usually a late sign, and they're not going to be in a good state at that point. You're kind of getting to that decompensating shock state where the body's systems and responses have already kind of starting to fail. Treatment goals for this shock state, but pretty much every shock state, is going to be rapid transport, rapid intervention if we can, if there's something that we can do. You don't want to waste a whole lot of time trying to fiddle around and figure out what's going on. So we're going to try and save the brain and kidneys. These are obviously the heart as well, because you need the heart to pump the blood, but the brain and the kidneys are kind of what's responsible for filtering out the waste material from the blood that's already in a bad state. And then the brain obviously is in control of the response mechanisms for the shock states. So we're trying to ensure that these systems maintain adequate blood flow. The best indication for cerebral perfusion is the patient's state of awareness. So we want to keep a constant eye on their level of awareness. They're answering questions. Are they becoming confused? Are they not answering questions appropriately? Stuff like that, right? So that's usually our first indication that they're starting to decline. And it's a pretty good indication of their level of kind of acuity for these shock states. With hypovolemic shock or hemorrhagic shock, we want to prioritize the control of the bleeding. So I always think of it going back to a CAB style of assessment versus ABC. Because if we're losing, I've said this before, if we're losing all of our blood onto the the kitchen floor from a knife injury, there's not going to be any point of resolving an A and B if we can't get that oxygenated blood circulating through the body appropriately, right? So managing the bleed has become kind of more the focus. It's more of a change or a shift in the past, I'd say 5 years, is we really want to, take that hemorrhage control, bleeding control, direct pressure, tourniquets and stuff like that, and really put that, up on a pedestal and take care of that if we can. And then, hopefully get the rest of the stuff managed, if we're able to manage that appropriately. Important to remember, if you work in a service that's going to be IV autonomous, which most places are now, you always want to take care of your hemorrhage control or your bleeding before you start administering fluids or worry about that. Again, because the most important thing that patient has is their own blood. We can try to resuscitate that blood loss with fluids, but the fluids that we administer can't carry waste products effectively, and it can't carry oxygen back to the tissues, right? So we're the patient's better off keeping their own blood in by having us control the bleeding first, and then after it's controlled, we can administer fluid volumes if possible. Again, we're not going to be giving them anything orally, so nothing NPO is what's called, nothing per hour. And I mentioned earlier too with the sensitivity to temperature changes, because they don't have proper blood volume. We want to avoid cold temperatures. And you can remember that from the trauma triad of death as well. So cold temperatures, acidosis, we want to avoid that. So some high-risk patients for hemorrhagic shock, patients that are suffering from a pelvic or femur fracture. Again, pelvis, we've talked about pelvic binding. Femur fracture, they talked about, I'm not sure, I think you guys have done your Sager and stuff like that already, but this is going to, try to protect those large arteries that travel through those areas, right? Severe widespread burns, we've talked quite a bit about fluid shifts from burns. Heat exhaustion, so heat exposure where you've diaphoresed and sweat a lot of your fluids out. Excessive vomiting, diarrhea, profuse internal, external bleeding or vaginal bleeding. So obviously people that have profuse bleeding, they're going to be at high risk of shock state, if that wasn't obvious. And then these patients here as well, you want to take into account people dealing with blunt traumas to the abdomen. They can have internal bleeding that's not going to be obvious right away. It might take a while for that abdominal guarding to show up, or distension of the abdomen. And then you might also have patients that are dealing with trauma. They also have neurogenic shock going alongside the hypovolemic shock, or they could also have an infection state that's developing, such as septic shock, which would kind of compound the problem. So when we're talking about management of these different shock states, there's just a few kind of pointers that the slideshow had for each one. So for cardiogenic shock, we don't really have good mechanisms to really resolve this in a pre-hospital setting. There are some tools we have in the ACP scope, but as a PCP, we really are limited to, if the patient's VSA and in a shockable rhythm, we can resolve that dysrhythmia. They're looking at adding vagal maneuvers for SVT, which would be, a potential way that PCPs could solve cardiogenic shock states. But other than that, you're looking at, being time sensitive, getting the patient to the hospital, and, administering fluids to help, boost up their fluid volumes if it's required. Neurogenic shock, important things to remember is, although you're dealing with the shock state and blood vessel or blood volume problems, we still have to remember we got to immobilize our patients. They are dealing with a traumatic injury, right? So we don't want to provoke the problem any worse by, having the possible SCI being a permanent SCI, or maybe it was something that was, maybe it was an unstable fracture that we provoked by moving them incorrectly. So you always want to take the time to immobilize the patient properly and adequately. And with neurogenic shock, remember the blood's going to be uncontrollably kind of pooling in those vascular beds that are below the injury site, and that blood is not going to be properly thermoregulated. It's going to be allowed to go right to the surface. It's going to be exposed to the whatever environment you had the patient in. So you want to keep them warm because that blood's going to be exposed to whatever environment you have it in. Management anaphylactic shock. You're going to want to act fast. Again, you're dealing with airway, breathing compromise as well, along with the actual shock state that the patient's going to be in with the vascular response. If it's possible, you want to try and remove that allergen from the patient. If it's something like a I don't know, like a chemical or something on their skin, like a cleaning product or detergent, maybe. You're going to want to provide airway and breathing support as well as your cardiovascular support, as all these systems are likely to become compromised, which is why acting fast is going to be paramount for this patient. We're going to be considering the use of epinephrine antihistamines, so we have Benadryl on board as well. And you might also be going down the route of using medications such as bronchodilators and antiemetics to help support this patient with their signs and symptoms. So if they're dealing with bronchoconstriction and nausea, vomiting, they might get medications from those other directives. So being well versed in your anaphylactic, or your your allergic reaction directive, your bronchoconstriction directive, and your nausea vomiting directive would be good for this point, and it might show up on the test. So that's all I have for the shock stuff. Well, not that's all, but I mean, I hope it seems to have followed a little bit better flow. I felt like the PowerPoint presentation was, like, again, all over the place. So I'm hoping this makes a little bit more sense, or some sense at least. If there's any questions on it, shoot me an email. I'll answer anything I can, or if there's something that's unclear, I'll maybe send like a group email out to everyone. So I'm just gonna finish this off. There's some IV therapy theory stuff which we'll go through, and it just kind of fits in well because we talked about the hemorrhage control and shock states with this chapter. So it's I'll just throw this in right now. It'll be tied into the same video. So when we're looking at IV therapy, whether it be for a shock state or any other reason that's requiring to have a large volume of blood, or not blood, a large volume of fluid administered to the patient, we should always review our ALS fluid therapy directives to kind of see what we're allowed to do, because it changes based on the patient's state, their age, if they're post cardiac arrest or not. So there's definitely some little nuanced changes that you might want to become familiar with if you're looking at the IV therapy directives. But when we're looking at dealing with shock and IV therapy for people who have either dealt with a large amount of blood loss or distributive shock states or something like that, we're looking at trying to infuse this IV solution as quickly as we can. So this is what we call a fluid bolus in the medical field. And we're doing this to try and resuscitate the vascular volumes that have been depleted or lost through one of these shock states. So things we're going to be looking to do, if again you're in an IV autonomous setting, is you want to try and get larger bore IVs because they allow a larger amount of blood to, I keep saying blood, a larger amount of fluid or electrolyte solution to flow into the patient's system. If you really have a lot of resources or time, you can start 2. But again, the actual amount of fluid we can administer is going to depend on the directive and the patient's condition that they're exhibiting. So make sure you review the ALS. Starting the 2 IVs isn't an issue. It's just you want to make sure that you are able to maintain and manage how much fluid you're actually administering, so you don't run into problems with fluid overloads or IV site complications and stuff like that. One thing we use quite often with these patients is what's called a pressure infuser. I drew a little sketch of one here. It's basically a bag or a sack, and what happens is you kind of slide your IV fluid into a pouch inside of this bag, and it has what's kind of like what's on our blood pressure cuff, so a little a ball pump on it, and you'll squeeze this to fill up this white bag, and it'll actually create a squeeze or pressure on the IV solution, which will help force it down the IV line and into the patient. A few things to remember with these is because it's just a bag full of air that's squeezing on the IV bag, as the IV bag actually depletes or starts to empty, the pressure that it's exerting on it will decrease as well. So you might have to fill up the pressure infuser a little bit more as the IV bag empties itself out. Pressure infusers typically work with liter bags, like a 1 liter bag of saline solution. So a lot of us carry small 250 bags, so you have to swap it out, put a liter bag in for it to be really effective. But finally, again, the most important thing to remember is with these patients, while doing the IV interventions, and the care is, fun and exciting, and, it helps our skills and helps us become better practitioners. At the end of the day, this patient needs to have rapid transport to get to a surgical or medical intervention that's going to actually permanently resolve the problem. So we shouldn't be delaying time on scene to do any of this stuff here. Okay, so in just a couple other things with IV theory, it's a quick one slide thing. When we look at IV solutions, they're usually trying to replenish a depletion of a certain electrolyte. So the major electrolytes that we have in our body are sodium, potassium, calcium, magnesium, and chlorine. And there's also a compound of hydrogen and phosphate, which is kind of a molecule, not just an electrolyte. But sodium is our most abundant cation, and chlorine would be our most abundant anion. So if you know what we give, NaCl is the normal saline that we all give in most pre-hospital settings. Some other services outside of Ontario might give lactated ringers, which has a few other things in there, like I think it's magnesium or something like that, but that's not something that we give. Some important things to remember when we're talking about dealing with IV infusions and adding products to our blood is that the normal pH of our blood is a range anywhere from 7.35 to 7.45. And remember that, as your pH reduces, that's more acidotic, and as it increases, it's more basic. So having our pH in this range is essential for survival. A lot of our enzymes, proteins, cellular functions, and metabolic pathways all kind of rely on things kind of being in that range of a pH. There are settings in our body, like our stomach, which obviously have a lot lower of a pH level, but as far as normal metabolic function in our blood and perfused tissues, it's going to be somewhere in this range from 7.35 to 7.45. The big systems that manage this are our buffer systems, respiratory system, and the renal system. And the big one with the buffer system is called our bicarbonate carbonate acid buffer system. And what's bicarbonate, which is HCO3, is actually circulates in our blood. And trying to see, carbonic acid, trying to see if there's an easy way to compare this, is what will actually release carbon dioxide when we exhale carbon dioxide from our breathing. So you can see here that this compound, or this buffer, is actually used to kind of hold on to some of the carbon dioxide, and it allows some of it to kind of stay in our blood system without it being just free floating carbon dioxide. So it kind of keeps a certain amount of it in our system, and it kind of gives our blood a little bit of a resistance from quick or rapid fluctuations in pH. So when it says buffer, it's kind of like from a chemistry standpoint, but these compounds, these components, allow a certain amount of base and a certain amount of acid to be added to the blood without it actually causing it to swing wildly in pH really quickly. There's other buffer systems in the body as well. There's phosphate, hemoglobin, and protein systems. They're not as widely used as the bicarbonate system and the carbonic acid. And if you get further into endocrine system and eventually like in ACP's school, we talk about it quite often when you look at end titles and airway management stuff. So the buffer system is a pretty important system. It's not something we're going to go too far into depth right now. It's just kind of a thing you should be aware of that helps manage our pH. Respiratory system, I've talked about this quite a bit with end titles. As we increase our ventilations, we can blow off excess CO2. And if you think of what I just set up here with the buffer system, as we release CO2, we reduce our carbonic acid in our system, which will help bring our pH back up, right? So it says here, blowing off CO2 reduces carbonic acid in circulation, and our pH will go back up. Obviously, conversely, the opposite would happen if we decrease our respiratory rate. We're going to kind of retain that CO2, and carbonic acid is going to build up in our system, and our blood will become more acidotic. This is mainly regulated in the medulla of our brain, as with everything else their blood seems to be. So remember, we have that system where we run off of how much carbon dioxide's in our body, and that's kind of based mainly off of our pH alone. Extreme swings in respiratory rates can lead to respiratory acidosis and alkalosis. So remember, this is fluctuations in the carbon dioxide that we breathe off, whereas metabolic acidosis would be from actual cellular function causing the acidotic or alkalotic state. And the final system is the renal system. Obviously, the kidneys, they take care of our blood all the time. So they're actually able to secrete hydrogen ions, which is essentially just what makes something acidotic, directly in the urine. They obviously secrete other things like electrolytes and ions as well, but its ability to just secrete hydrogen ions alone is a pretty strong kind of acid balancing system that our body has. So this is important to kind of recognize that that's why the solutions that we give are all supposed to be isotonic. So it's not supposed to change the pH. It's not supposed to change the salinity. It's going to be, it's not going to cause shifts in fluids in and out of cells. So if we are able to recognize, things that might shift these, like when we talk about respiratory issues, having a good understanding of our buffer systems will help you, comprehend why somebody's end tidal goes low when they are breathing rapidly. And then if you think of if they're going to be in an acidotic state, then you might understand, or you might kind of appreciate, there's other risks associated with that, such as, oxygen won't load onto hemoglobin appropriately. Cellular dysfunction might happen in the heart. Cellular dysfunction might happen at other tissues and organs because they're in an acidotic state. So having a good understanding of what our normal ranges are and what happens, or what the human body can do to kind of force itself out of its normal range, will help you kind of appreciate what dysfunction will look like, or what changes in those normals might kind of present as in the pre-hospital setting. Anyways, that is all I have for this content. Like I said, it was a little longer winded than I was expecting it to be, but I hope the layout of this makes a little more sense than the slideshow did. I was trying to record it from the slideshow directly, and it was just such a mess that I just felt like I would do it this way. So I'll send this PDF, I guess, with the email, and then if you guys have any questions with the slideshow content with this and the video, and email me. But yeah, this will be all for Unit 6, and I'm going to be recording a pharmacology video hopefully in the next day or so. So I hope you all are doing well, had a good holiday, and you're able to get some studying in. And we'll talk soon. Take care. Bye.